52-year-old male, episodes of speech disturbance in the previous month, neurologically intact at the admission. This is a preoperative MRI, and we can see that this patient presents a big tumor on the right frontal lobe in a very deep location, and it presents intense contrast enhancement, and it goes all the way to the head of caudate nucleus over here, and it will infiltrate the genu of the corpus callosum up to the level of the septum pellucidum. And also the same patient presents another tumor with similar features on the left side. And this is the coronal cut. Once again, axial cut, infiltrating here, see the genu of the corpus callosum and also a part of the body of the corpus callosum. And here we have the tumor located on the left side. So where is this tumor located in relation to the surface anatomy, for instance here? As we remember, insula is related to the anterior half of the insula is related to the pars triangularis, opercularis, and the posterior half of the insula is related to the precentral gyrus and then postcentral gyrus. So this tumor is located right deep, but on top of the pars triangularis over here. So the tumor is located here. So how can I approach this tumor? One thing that we can use is this sulcus. This sulcus, probably the inferior frontal sulcus, is located approximately 4 centimeters above the sylvian fissure. So if I split and open this sulcus, at the bottom of the sulcus, I'm very close to the tumor. So this might be a good route to access this tumor. So now let's analyze the preoperative MRI of the tumor located on left. So we see that tumor is located right above the sylvian fissure. So actually it is located at the operculum. Operculum of what part of the frontal lobe? Is it pars opercularis, triangularis, precentral, postcentral gyrus? So let's check it out here. This is a sylvian fissure, sagittal cut, and this is actually the pars triangularis. So this would be the pars opercularis. So actually the tumor occupies the location of the operculum of the precentral gyrus on the left. So this actually is the tumor that generated the symptoms of the patient, which was speech disturbance. So for the preoperative imaging for brain tumor, it is important to observe veins, sulci, and other special details. We have to observe the extent of the tumor, the entry point to the tumor, the shape of the tumor, the boundaries of the tumor. What are the medial, posterior, anterior, superior, and inferior limits of the tumor? And also the differentiation between the normal gray matter versus normal white matter versus tumor. Quick comments on the preoperative imaging for the right frontal tumor. The best entry point for this tumor is an anteroposteriorly oriented sulcus located approximately 4 centimeters above the sylvian fissure, just behind the pars opercularis or at the level of the precentral sulcus. Probably it is the inferior frontal sulcus. From there, the surgeon will have equal access to the whole extent of the tumor. At the end of the tumor removal, the right frontal horn will be opened. The level of the septum pellucidum could serve as a landmark to assess the end of the tumor removal at the genu of the corpus callosum, as the tumor goes just a little beyond the midline towards the left side. So this is the sulcus, what I was talking about. If you open the sulcus, get to the bottom of it, and then you are very close to the tumor. So here we have the exposure of the brain on the right side after the right frontoparietal craniotomy. The Sylvian fissure, right Sylvian fissure is over here. The anterior part of the head is over here. The occipital lobe will be here, and the midline will be here. So let's see the video. So what you're going to do next is to open this sulcus over here. Very gentle movement once again, because the brain is swollen. It's a very wonderful micro surgical technique. So the more you open, the larger will be the space you will gain to access the tumor. So I've opened widely the sulcus. It's very deep, and at the bottom of the sulcus now I can find the white matter, and then I was very quick and very close to the tumor. So we can see the abnormal color of the tumor. See, for this kind of high-grade glioma, it's very easy to distinguish what is the normal tissue, what is the tumor tissue. You see the dark color, it bleeds a little bit, and this is a normal white matter on this side. This is the posterior part. So I just kept following the tumor with suction, coagulation, and you can use also the ultrasonic aspirator. Sometimes I use spatula to keep the space open, and just keep working, removing until you find the normal white matter. I like very much bipolar forceps with irrigation, so it won't stick. And also I use glucose 5%, and it will not stick because sometimes it irritates. Here is the opening of the frontal horn. We know that the tumor will be tumor in front of the frontal horn, which is the anterior wall of the frontal horn, the genu of the corpus callosum, and also at this part, which would be the head of caudate. So I'm expecting to find some normal gray matter over here, but I'm not expecting to find gray matter over here because I'll be at the corpus callosum. So just gently remove everything, and once again, here's the frontal horn is opened. I know that the medial limit will be at the genu of the corpus callosum, but at the level of the septum pellucidum. The septum pellucidum marks the midline. Now I'm using the ultrasonic aspirator to speed up the tumor removal. So this is still tumor tissue, all tumor here. Here, this part is probably normal, but here we still have tumor, and some part of it may be normal white matter, but not complete. Much more tumor over here. We have to remove more. So it is very important to know what is the aspect, what is the appearance of the normal white matter, what is the appearance of the normal gray matter. So that's how we use to distinguish from the brain tumor, the aspect of the tumor. So just removing, coagulating using irrigation And this is the final aspect after the removal of that tumor. About 3 weeks later, the same patient underwent the left terional approach to remove that the tumor on the left side. So here is the left sylvan fissure over here, and here we have this bulging. This is a temporal lobe, this is a frontal operculum. So where's the tumor? You can see that over here. Just look at the veins. You see the superficial sylvan vein over here is very dark. This is a normal aspect of the vein. But you can see here, this vein is like arterialized, with arterial blood mixed with the venous blood. So it's more red than this one. So now you can see this abnormal color, the red color over the sylvan fissure. So actually the tumor came to the surface for us. So some people might ask, why don't you do this awake surgery? We don't have to, because the tumor comes to the surface. If we check the preoperative MRI, you can see that. So let's see the video. So once again, we're opening the sylvan fissure where the tumor comes to the surface, and opening more around an artery to create more room, and so I can retract more, if necessary, the brain tissue. So careful movement. The tumor was right under the arachnoid membrane, so I'm working inside the tumor and not damaging the normal brain tissue. Getting samples of the tumor is very suggestive of high-grade glioma, glioblastoma. So I'm also, once again, working inside the tumor and trying to see what's the normal gray matter and what is the normal white matter. But so far, only tumor. So little by little, the appearance of the normal white matter can come up, but so far it's all tumor. Suction, coagulation, removal, always working inside the tumor and keeping the arachnoid membrane intact on this side, because the arachnoid membrane will protect the branches of the MCA. So at this point it looks like a normal white matter to me. Here we have more normal white matter, still some tumor over here and here to be removed. Here's normal for me, and this is the end of surgery with apparently normal white matter and gray matter. And here we have the preoperative imaging, and here we have the postoperative MRI with the gross total resection of the tumor. And here we have the postoperative CT of the removal of the tumor on the left side. The histology was glioblastoma, and he remained neurologically intact after both surgeries performed in 2011. He underwent radiation therapy and chemotherapy in 2011, but he died in 2014 after tumor recurrence.